Hello, today we will discuss about how to approach with syncope. Uh, this is a man with syncope. First clinical scenario, case 1, 42 years old female, chief complaint passing out of at work, who works in a pharmaceutical lab, was sitting at her desk, felt nauseated and knew she was going to pass out. For witness, was slumped over the chair, was unconscious for a few seconds. Similar episode 10 years ago, no family history of sudden cardiac death, no medication, no smoking, no alcohol, no drugs. And the case 2, 82 years old male, found unresponsive by his son, past medical history of hypertension, medication, hydrochlorothiazide, examination, BP 162 per 98, pulse 96, now alert and oriented. Facial conditions are there, otherwise normal examination. Now question is, how would you manage these two patients? We will discuss it later. Now syncope definition. Definition is a transient loss of consciousness associated with absence of pleural tone, followed by rapid and complete recovery, absence of prolonged confusion, result from global cerebral hypoperfusion, pre-syncope, prodromal symptoms of fainting, and typically has the same workup as the syncope. Syncope pathophysiology, it is when decreased cerebral perfusion is common to all cause of syncope, and cessation of cerebral perfusion for as little as 3 to 5 seconds can result in syncope, and decreased cerebral perfusion may occur as a result of decreased cardiac output or decreased systemic vascular resistance. Classification of syncope is mainly non-cardiac, orthostatic, neural mediated, and vasovagal. And non-cardiac typically involves prodromal symptoms that leads to loss of consciousness, muscle tone for less than 30 seconds, and recovery within seconds. Orthostatic hypotension symptoms, syncope symptoms triggered by postural changes. Common causes include dehydration and autonomic neuropathy, commonly seen in patients with diabetes. Neurally mediated reflex syncope, subclassified into carotid, sinus, situational, and vasovagal syncope. Vasovagal is the most common. So vasovagal is a part of neurally mediated syncope. Now, vasovagal syncope is sudden increase in vagal tone triggered by prolonged strain, emotional stress, painful stimuli. Patient may experience prodromal symptoms of nausea, warmth, diaphoresis prior to syncope. Now, classification again. Cardiac syncope does not typically involve prodromal or postdromal symptoms. Patient may have history of arrhythmia, valvular disease, structural heart disease. Skin for the following potential etiologies: left ventricular outflow tract obstruction, such as aortic stenosis, hypertrophic obstructive cardiomyopathy, syncope with exertion or during exercise. And arrhythmia should be ruled out, history of COD, MI, cardiomyopathy, PW symptom or reduced TF. Trousers deep only should be ruled out, is triggered by electrolyte imbalance. Some clues to the etiology of the syncope. This is if syncope is cough, micturition, defecation, or swelling associated with situational syncope, part of reflex syncope. Syncope with arm exercise is subclavian steal syndrome. Syncope with shaving, discrete sinus syncope, part of reflex syncope. Syncope with change position, it is orthostatic syncope. Prodromal symptoms like nausea, diaphoresis, it is neurally mediated reflex part known as vasovagal also. Syncope with exertion. It is like example like aortic stenosis, ISSS, and arrhythmias. It is part of cardiac syncope, and it is a abrupt onset. It is cardiac syncope. It is a blood pressure or pulse differential if there is present. It is maybe aortic dissection, subclavian still syndrome. Post-syncopal disorientation incontinence. It is mainly related to seizure, not syncope. Dynamic systolic murmur that intensified from a squatting to a standing or during Valsalva maneuver with family history of sickle cell disease. It is you should consider hypertrophic orthostatic cardiomyopathy. Close to the etiology of syncope, initiation or change in doses, um, like alcohol, anti-anginal agents, antidepressant, and anti-diabetic, antihypertensive, anti-Parkinson's disease, diuretic, insulin, refers to orthostatic hypotension syncope, which is drug induced. History of acute blood loss like GI bleeding, ectopic pregnancy, diarrhea, inadequate fluid intake, vomiting, orthostatic hypotension syncope due to volume depression is present with hypotension, tachycardia, dehydration on examination. Young adults, predominantly female, associated with chronic fatigue syndrome and mitral valve prolapse with severe orthostatic intolerance with marked tachycardia. It may be defined as postural tachycardia syndrome, which is part of orthostatic hypotension syncope. Close to the etiology of the syncope. Tongue biting, incontinence, prolonged confusion, it is seizure, not syncope. Use of macrolides, antiemetic, antipsychotic, tricyclic antidepressant. Think about prolonged QT interval. Alcoholism, DM, multiple sclerosis, and amyloidosis, Lewy body dementia, older age, spinal cord injury, uremia, Parkinson's disease, renal replacement therapy. Think about orthostatic hypotension syncope. Elevated jugular blood venous pressure, hypotension, pulsus paradoxus, sinus tachycardia. Think about cardiac tamponade. And now, what history you should take? Detailed history should be taken and decide mainly these three things. Is the loss of consciousness attributed to syncope? Number two, is there is a history of cardiovascular disease? Number three, are there is clinical features suggest a specific cause of syncope. Red flag symptoms for syncopes are exertional onset, chest pain, dyspnea, low back pain, palpitation, severe headache, focal neurological deficit, diplopia, ataxia, or dysarthria. These are the red flag symptoms. You should always consider this one. Diagnosis of syncope. The static point of diagnostic evaluation is of transient loss of consciousness of suspected syncopal nature is the initial syncope evaluation, which consists of careful history taking concerning present and previous attack as well as eyewitness account in person or through a telephonic interview. Detailed physical examination includes supine and standing, BP measurement, and cardiac and nervous system examination. ECG and serum glucose and electrolyte should be taken. Based on this finding, additional examination may be performed when needed. Immediate ECG monitoring when there is a suspicion of arithmetic syncope. Echocardium when there is previous heart disease data suggestive of structural heart disease and or syncope secondary to cardiovascular disease or cause. Two tools are used to diagnose syncope. The one is carotid sinus massage and head tilt testing. Carotid sinus massage in patient aged greater 40 years. Diagnostic if ventricular pulse is more than 3 seconds or if systolic blood pressure decreases by more than 50 millimeter mercury. Contraindicated in patient with bruise or history of transient ischemic attack or cerebrovascular accident within the past 3 months. Well, now head up tilt testing when there is suspicion of syncope due to orthostatic hypotension or reflex syncope. Used in patients with negative initial findings, normal cardiac structure, and no evidence of ischemia. Contraindicated in patients with ischemic heart disease, uncontrolled hypertension, and left ventricular outflow tract obstruction or aortic stenosis. Diagnosis of syncope blood test when clinically indicated, e.g., such as hematocrit or hemoglobin when hemorrhage is suspected, oxygen saturation and blood gas analysis when hypoxia is suspected, troponin when cardiac ischemia related syncope is suspected, and dimer when pulmonary embolism is suspected. Here is a chart for classifying which is high risk and which is low risk. Syncopal event low risks are associated with prodrome of typical reflex syncope such as lightheadedness, feeling of warmth, sweating, nausea, vomiting, after sudden unexplained unpleasant sight, sound, smell, or pain. After prolonged standing or crowded hot place during a meal or post-prandial triggered by cough, defecation, or masturbation with head rotation and pressure on carotid sinus such as tumor, shaving, tight colors, standing from supine or sitting position. It is a low risk. And which are high risk? There are two types, major and minor. Major are new onset of chest discomfort, breathlessness, abdominal pain, and headache. Symptom during exertion when supine. Sudden onset of palpitation immediately followed by syncope. Minor criteria are high risk only if associated with structural heart disease and abnormal ECG. The criteria are no warning symptoms or short warning symptoms less than 10 seconds prodrome, family history of SCD at young age, syncope in the sitting position. From past medical history, low risks are uh, long history, uh, um, maybe years of recurrent syncope with low risk features with the same characteristics of the current episode, absence of structural heart disease. High risk features are major severe structural coronary heart disease, such as heart failure, low left ventricular efflux, ejection fraction, or previous myocardial infarction. Now, physical examination. From physical examination, there is low risk is normal examination, and high risks are major high risks are you see here unexplained systolic BP in ED less than 90 millimeter mercury, suggestion of GI bleed or on rectal examination. Persistent bradycardia less than 40 beats per minute in aortic stents and absence of physical training, undiagnosed systolic murmur. ECG, and there is also low risk and high risk criteria. Low risk are normal, and high risk are major and minor. Major mm, are ECG changes consist of acute ischemia, Mobis type 2, second or third degree block, slow F, less than 40 beats per minute, persistent sinus bradycardia less than 40 beats per minute, or repeated sinoatrial block or sinus process grade 3 second in aerobic state or in absence of physical training. Bundle branch block, interventricular conduction disturbance, ventricular hypertrophy, or QFs consistent with ischemic heart disease and cardiomyopathy. Sustained or non-sustained BT, dysfunction of implantable cardiac device, pacemaker or ICD. Type 1 Bogota pattern, ST segment elevation with type 1. Morphology in leads B1 to B3, which is Bogota pattern, QTC grade 460 millisecond in repeated 12-beat ECG indicating long QT syndrome. Minor high risk if history consisted of arrhythmic syncope, such as Mobis type 1, secondary AV block, and first degree AV block with markedly prolonged PR interval, asymptomatic inappropriate mild sinus bradycardia 40 to 50 beats per minute or slow F, paroxysmal supraventricular tachycardia and atrial fibrillation, pre-excited QRS complex, short QTC interval, less than 40 millisecond, atypical Bogota patterns, negative 2 Fs in the right precordial leads, epsilon wave suggesting ARVC. ARVC means arrhythmogenic right ventricular cardiomyopathy. Now, how to approach after syncope, after evaluation in ED, there is if low risk features only, this is likely reflects situational or autistic, can be discharged from ED. And if it is neither high nor low risk, should be discharged from should not be discharged from ED, means emergency department. ED and hospital syncope observational unit, if available, they will be there. And after evaluation and everything, syncope outpatient clinic, they will follow up there. And also, there is if this low risk and recurrent attack, they will evaluate in syncope outpatient clinic. And if there is high risk feature, and they should be admitted for diagnosis and treatment. Any high risk feature require intensive diagnostic approach, should not be discharged from ED. So keep it in mind. Now, this is not too much important, I already told. In short, there is for evaluation syncope, this is by American College of Family Physicians, they suggested this one. Transient loss of consciousness, initial evaluation, history and physical examination, orthostatic blood pressure measurement, ECG, laboratory testing as indicated. If there is non-syncopal transient loss of consciousness, treat based on etiology. It is suspected syncope, significant trauma. There are four categories. It may be autistic hypotension syncope, it may be neurally metacardiac syncope, or unexplained syncope. If there is autistic hypotension syncope, modify the risk, education, pharmacotherapy, If neurally mediated symptom tip, you do head tap tilt testing and chaotic sinus, and it is after this testing, if it is diagnostic of neurally mediated, then avoid precipitating factor education pharmacotherapy after this diagnostic. If not, it is negative, then consider cardiac syncope and psychogenic pseudosyncope. And if frequent syncopal episode should be, if that is the case, psychogenic pseudosyncope is the case, then and there is frequent syncopal episodes, psychiatric consultation, video, EEG, Holter, and external loop recorder, and infrequent should be implanted, and infrequent syncopal episode, external and or implantable loop recorder should be implanted. And if it is not psychogenic, then go to a means cardiac syncope. And for cardiac syncope and unexplained syncope, stratified, which I tell you before this, in previous slide shown yellow box and green box like this. You should to risk stratified from there. And if there is low risk, frequent syncopal episode, Holter, external loop recorder should be implanted. Infrequent syncopal episode, implantable loop recorder should be implanted. And if this high risk, ECG monitoring, echo as indicated, carotid sinus meningitis is indicated, electrophysiology is indicated, and exercise stress testing is indicated, head tilt testing is indicated. This all should be done preferably as after admission. And if it is diagnostic of cardiac syndrome, treat. If not, no, still not diagnostic, then you can put implantable lobe recorder. Treatment: neurally mediated syncope. Treatment of neurally mediated syncope include reassurance, education, physical therapy. Institutional syncope, it is important to avoid triggers, physical counter pressure measures such as leg crossing, squatting, and tensing. The lower extremities are effective at the onset of prodromal symptom. One randomized trial showed that these maneuvers reduce syncope by 39%. Tilt training involves standing for prolonged periods, and compliance is generally poor. Pharmacologic therapy with beta blockers, alpha agonist, and photocortisone has shown no effectiveness and conflicting result in reducing vasovagal syncope. In one small randomized trial, a patient a history of recurrent vasovagal syncope, paroxetine prevented additional episode in 82% compared to 47% in placebo group over the 2 years. P is less than 0.001. Although guidelines recommend its use only in patients with concurrent psychiatric diseases. In patients with severe asystole from neurally mediated syncope, a double-blind randomized placebo-controlled trial showed that the use of permanent dual-chamber pacing reduced the risk of recurrent syncope. For orthostatic hypertension, treatment of orthostatic hypertension includes education and lifestyle medication, and slowly transitioning from supine to sitting position and standing, and increasing fluid and sodium intake. Contributing medication should be discontinued or decreased if possible. Other treatment modalities include elevating the head of the bed by 10 degrees, compression stocking or abdominal bandage, counter pressure measures. If these do not mitigate symptoms, midodrone and photocortisone are effective treatment. And for cardiac syncope management, cardiac syncope directed as underlying Etiology options include antiarrhythmic drug, cardiac pacing, catheter-directed ablation, and rarely mm, mm, implantable cardioverter defibrillator, which is ICD, with generally this replacement of this ICD. And for case which I told you before, case 1, continuous physical examination is normal, orthostic normal, EKG came out normal, and lab no anemia, glucose normal, echo normal. Tiltable test after 7 minutes of shift, 70 degrees upright, uh, heart rate become 36 and BP 51 by 41, loss of consciousness, regain consciousness with supine position. So conclusion, diagnosis, vasovogal syncope, outcome, no recurrence of syncope, and follow up at 3 months, 6 months, and 1 year later. Case 2, continuous emergency room, workup negative, electrolyte CPC normal, EKG shows normal sinus rhythm with occasional PVCs. Decision was made to admit towards later non-sustained ventricular tachycardia. EPS study shows inducible BTEC, automated internal defibrillator was placed, and cardiac cath, diffuse coronary disease was found. Some key recommendation for practice: patient who present with syncope should be evaluated similarly to this who present with syncope. Patient with syncope and evidence of congestive heart failure and structural heart disease, abnormal ECG findings, and family history of sudden cardiac death should be admitted to hospital for emergent evaluation. Patient presenting with syncope should have orthostatic blood pressure measurement and a standard 12 lead ECG. Laboratory and imaging studies should be ordered for patients with syncope only if clinically indicated by history and physical examination. Implantable low placators increase diagnostic yield, reduce time of diagnosis, and cost effective for suspected cardiac syncope and unexplained syncope. Patients with syncope who are at low risk of adverse with those with in example, those with symptoms consistent of vasovagal and orthostatic hypotension, syncope, or no history of heart disease, no family history of sudden cardiac death, normal ECG findings may be safely followed and without further intervention and treatment. Best practice for neurology recommendation from those who the Choosing Wisely campaign. American College of Emergency Physicians, they suggest avoid CT of the head and in asymptomatic adult patient in the emergency department with syncope with insignificant trauma and normal neurologic evaluation. American College of Physicians, they suggest in the evaluation of simple syncope and normal neurologic evaluation do not obtain brain imaging such as CT or MRI. American Academy of Neurology, they do not perform imaging of the cardiac, imaging of the carotid arteries for simple syncope without other neurologic symptoms. Now I will show you some ECG syncope related to syncope. This is ventricular fibrillation. You see this QRS is chaotic, wide, and Bezier and irregular. So it is ventricular fibrillation. This is a block. You see absence of PQRST complex, and PP and RR is double than the next PP and RR. This is thoracic depontis. This is BT with differential configuration of QRS. sometimes it is related for to electrolyte imbalance also. Ventricular tachycardia, you see, there is P is absent and QRS is brought more than 1.14 second and rate is greater 100. This is WPW syndrome. This PR is short, less than 0.12 second and QRS is wide. QRS is wide and this is a delta wave in the upstroke of QRS, slot QRS, this one, and QF may be present in the lead 2 3 see lead 2 3 and ABF confused with, sometimes may be confused with inferior myocardial infarction. This is complete heart block. Atrial rate is around 80, but PRE interval is constant and no relation between PUF and QRX complexes. Main thing is here no relation with PUF and QRS complexes at all. This is 2:1, 3:1 block. This is 2:1 heart block, and this is 3:1 heart block. When this is Bogota syndrome, this is you see this is the ECG B1, B2, B3. Cope type is T elevation and TF inversion in B1 and 2, B3. Treatment with ICD and quinidine, and treatment manifestation is like syncope and BTBF or sudden cardiac death at sleep, mainly due to the sodium channelopathy. Okay, this all I take from American Association of Family Physician Journals and European Society of Cardiology for diagnosis and syncope 2018 guidelines. This is the latest guidelines. Okay, thank you all. Thank you for listening.